Hi everyone, I am Rosalyn Anitha, nursing tutor in Tribhuvam College of Nursing. Today I am going to present the topic on urinary incontinence. Objectives: Introduction about incontinence, mention the anatomy and review of bladder, physiology of bladder, definition of incontinence, list the types of incontinence, explain the pathophysiology of incontinence, state the causes of incontinence, list the clinical findings of incontinence, mention the investigation of incontinence, explain the nursing management of incontinence. Introduction: Urinary incontinence is the complaint of involuntary leakage of urine. As the population ages, the numbers of older people with urinary incontinence will significantly increase. Urinary incontinence is classified as a major category of impairment that appear in elderly people, especially as they begin to fail, and it is one of the geriatrics. Incontinence: unable to retain the natural discharge or evacuation of urine or feces that leads to the urinary and bowel. Anatomical structure: detorus muscle is present, uterus is present, trigone, internal sphincter and external sphincter. Anatomy review: bladder stores urine, urethra, the tube that allows urine to pass, urethral sphincter, muscles surrounding the urethra that hold the urine. Physiology of bladder: autonomic nervous system control, nerve coming from the spinal cord and go directly to the bladder. When a bladder gets fuller, signals are sent to the brain. Central nervous system: voluntary control to choose when to void. Both can be altered by aging or neurological disease. Coming to the definition, urinary incontinence means there is a loss of bladder control which leads to unintentional passing of urine. Types of incontinence: stress incontinence occurs during certain activities like coughing, sneezing, laughing, etc. Urge incontinence: inability to hold the flow of urine when feeling the urge to void. In mixed incontinence, there is a combination of both stress and urge incontinence. Symptoms: an overflow incontinence, retention with overflow of small amounts of urine. Urgency is a sudden desire to void. Frequency is passing of urine 7 or more day or being awakened from sleep more than if one a night to void. Coming to the etiological factors, stress incontinence, there is a weakening of the urethral sphincter and pelvic floor muscles. Pregnancy, childbirth, age, obesity, menopause, surgical procedure, example hysterectomy. An urge incontinence, etiological factors are overactivity of the detorus muscles, cystitis, central nervous system problem, and enlarged prostate. Coming to overflow incontinence causes: obstruction or blockage to the bladder, and enlarged prostate gland, a tumor pressing against the bladder, and urinary stones and constipation. Coming to the pathophysiology, incontinence bladder occurs when this pelvic muscles that involves in urination get traumatized, either overstretched or tear that lead to weaken of the muscles, leads to, as the time goes by, the muscles become weaker until a certain point they cannot support the bladder anymore. And when there is high pressure for the abdominal, such as coughing, sneezing, lifting, or pushing heavy things, the bladder forces urine past the urethral sphincter, causing incontinence to occur. Coming to the clinical features: stress incontinence, cough, sneeze, laughing, lifting heavy objects, vigorous exercise, have sexual intercourse, standing in prolonged time. An urge incontinence, there is a frequent urination in a day at a night time, sudden urination and urinary urgency. An overflow incontinence, bladder neck feels empty, inability to void when urge is felt, urine dimples even after voiding. Coming to the investigation, Physical examination to identify the pelvic muscle prolapse, urine culture and sensitivity to identify the infections, pad test, and measure the post-voidal residual volume by bladder, ultrasound, or urethral catheter. And urodynamic studies, uroflowmetry, bladder outlet obstructions, cystometry, diastole bladder contraction activity, cystogram to visualize the bladder, cystoscopy to visualize the tumor and stone. Coming to the management, medications, anticholinergic medications, antidepressant medications, imipramine, duloxetine, topical estrogen, alpha and beta adrenergic antagonist, and phenylpropanolamine. Medical devices, urethral stent, FemSoft insert, pessaries, external condom, drainage in men's surgery. Surgery, slings procedure, bladder neck suspension, artificial urinary sphincter. Coming to the nursing diagnosis, stress incontinence related to the pelvic floor muscle, impaired skin integrity related to constant contact of urine with perineal tissues, ineffective coping related to inability to control the urine leakage. Coming to the nursing management, helps strengthen the muscle of the pelvic floor, improve the bladder stability, help suppress the feeling of urgency contraction, bladder relaxation, pelvic floor exercises, bladder training scheduled voiding at a side time during a day, active use of muscles to prevent urine loss, keep own input and output chart. Behavior modification, drink less than 5 glasses per day, stop drinking after dinner, elevate the legs, timed voiding, regular pelvic floor exercise. Coming to the conclusion, urinary incontinence can be the serious hindrance to everyday life. It is not an unavoidable result of aging but can result from a number of causes. There are many treatment options available. Doctors can help to choose the right treatment to regain bladder control. Thank you.